for you is I don't want to make the assumption that everybody knows what direct primary care is, right? It's really catching on. It's a national type of movement. But can you just explain to us in layman's terms, what is a direct primary care relationship and what does that mean?
Yes, so direct primary care is a membership-based model where the patient or the employer pays a monthly membership. And then when the patient comes in to see us, all their visits are included. There's no co-pays. There's no deductibles that they have to meet. There's no cost for that visit. So it includes all their memberships. And then we do provide other ancillary services at an additional cost. But the idea is that we are trying to kind of take care of as much in the outpatient setting as we can without having to refer people into the system for a lot of things.
Perfect. So here's a misconception I get all the time. Is direct primary care insurance?
No. So part of the way that this model can function is that we have eliminated a lot of the overhead costs associated with insurance. So we don't bill anything through insurance. It's what we consider a cash-based model. So again, the membership cost, whether that's coming through the employer or the patient, that is all just direct between the practice and the patient or the employer. And we're not submitting any of those visits through the insurance.
Perfect. I always try to use an analogy like a gym membership, like where it's a subscription-based membership club, essentially, where
Sure.
you pay that monthly subscription fee, you have access to the facilities just like a gym membership would, and they're not going to nickel and dime you for every single time that you go in there. It's built into the model, is basically what you're saying.
Yes, true.
Perfect. So another question for you on the direct primary care. When you started your practice, what was the original intent behind that? Was that like your love of medicine and the reason that you became a physician? Was it a hate for the administrative work that a lot of the big systems have now implemented? Or walk me through why you did what you did.
Yes. So when I started the practice, started the planning phases in 2018, and then the practice officially started beginning of 2019. But I had been an employed physician for about 10 years prior to that. And I think like many physicians right now in the system, very disillusioned with the current state of healthcare, disillusioned with how much time I was spending, in front of a computer, entering in notes and documentation that, again, is really a means of billing, right? It's not necessarily about the patient care. It's about how we're going to bill for that. So I had heard about this model from someone else, and I had been working actually as a hospitalist and emergency room doctor, and had pretty much left doing outpatient medicine for a few years, but I'd heard about this model where you can spend more time with patients.
Yeah.
You don't have to deal with a lot of the bureaucratic, paperwork stuff, and you actually, can see a lower volume in general of patients. So I thought, that sounds like something that would be really nice. And, so that's kind of my motivation to switch into the direct primary care model.
Love that. So I'm a big analogy person, as you know. If I were to ask you, let's just take something like groceries. Everyone has to buy groceries. If we were to associate a brand name of a grocery store to direct primary care and kind of what that relationship looks like in comparison to whatever the big box store, grocery store is, and what the large systems look like, using that analogy, how would you do a compare and contrast with that?
Yeah, there's an analogy with that I really like, where they kind of show DPC as like the Aldi's of grocery stores. So you look at big name, we've all know the big name systems in town, that have a lot of patients. They advertise a lot.
Yep.
You see their billboards up. So the care is much more expensive. They have a lot more, layers of corporate, administration. So the product itself, the household name, but it doesn't necessarily mean that the product tastes any better.
Right.
But you look at all these, it's all generic. So they have the generic Cheerios, the generic Oreos. And so it's high quality. And also the store itself, it functions very efficiently. They don't have a lot of employees in there. They might have 2 or 3 employees. They've kind of automated a lot of their systems. So in the direct primary care model, again, we try to keep our overhead low. We might have a less variety of things, less variety of doctors or less variety of locations, but all the doctors are very high quality. The services that we're providing are at least as high quality as the services you're getting in the big box system, but we're able to do that at a lower cost just because of our overhead being so much lower.
Love it. It's kind of like a car dealership, right? Like the ones with the fanciest buildings compared to the one on the roadside, the cost of
Yeah.
the vehicle is normally different because of the overhead, right? It's very,
Yes.
very similar to that.
Yeah.
So one of the things that we have been talking about for a while is coupling DPCs with HSAs and why we think that that's a big deal. There is a common theme if you look at all things healthcare from what was leading up to the election not that long ago to what employers are complaining about left and right every day, and that is access, right? Access is an issue, especially here locally. We have a lot of those access issues here. How do you think DPC can actually help with the access problem that we have? Because it's not like we can go out and hire a million a million doctors that are graduating tomorrow and put them into the field. We can't limit our panel sizes and just kick out. How can we solve some of this problem with DPC, do you feel?
Yes, and this is I guess a controversial point because as you've heard, Mike, there's some people that make the argument that we have a physician shortage. Doctors are retiring more. It's harder to see a doctor. So how are we now if we take more doctors out of the system to do direct primary care and they see lower volumes? The way I look at this is that the pendulum is swinging, right? It's kind of swinging in this direction of a lot of people now don't have access through the big healthcare systems. You don't see the motivation within those systems to kind of make major changes to provide better access.
Exactly.
Whatever
Yep.
that is, become more efficient strategically, somehow be able to do appointments easier. I don't know. But so you don't see the systems changing a whole lot. So now there's this huge room for opportunity within the DPC community that we now have physicians that we can get you an appointment tomorrow. We can get you an appointment in 1 week rather than 6 months or 9 months. So, as we've talked about between us, we have companies now that are looking at this. Obviously, there's a financial savings with this, but also just from the standpoint of, our employees are complaining that they can't get in to see a doctor. Or I heard somebody the other day, just to give you an example, complaining that this person had been trying for a year and a half to see their primary because they were assigned a primary, and 6 or 7 months was the appointment, and then a week before the appointment they were called and the appointment was canceled or rescheduled for another 6 months away, and then it was rescheduled again. That doctor left the system. They were scheduled with a PA or a nurse practitioner. That person, so it's crazy what's happening right now. But again, on our end of things, we look at this as an opportunity, and we look at it as, we're satisfying some need in the community that people need access to healthcare, right? And so if we can keep that low cost and high quality, and as you mentioned, with the high deductible health plans, we look at it as we're filling that gap so if you have a $5,000, whatever your deductible is, if you have a DPC membership and 1 year of membership is $800, let's say, for example, so you're going in to see us for everything that you need. Maybe there's one time a year where you have to go into the system to get your mammogram or your colonoscopy, or, but we're satisfying everything else. That's going to be a huge cost savings for that employee or that patient.
Yeah, it's to give everyone a little bit of context too on why we feel very strongly about how this clarifies DPC and HSA relationships. Before this bill was passed, it was definitely a gray area where particularly the IRS was looking at a DPC membership like it was a insurance health plan, right? The DPC community is like, we don't even take insurance. We're a membership fee access organization. So now the big beautiful bill basically clarifies that, because now they're saying we can actually use HSA funds to pay for my membership. 150 for a single, 300 for a family. You can use HSA dollars for medical costs that are incurred outside of that as well. Like if you have to have a simple lab done. So now we got rid of that. Now we have clarity that the government is basically going to allow this as not viewed as first dollar coverage and jeopardize your HSA funds. Why this is important is there are studies that show that HSAs will decrease in utilization for healthcare, especially things like primary care services, because you don't want to pay out of the pool of money that you're having in there. Now that gets alleviated. It's kind of the best of both worlds. You can invest in your own health with a DPC relationship and still have overarching coverage that you can save for things that would happen outside of your four walls. That's a really big deal. Before, they didn't have that clarity. With that clarity, how do you think that's going to impact your business now, Dr. Hemkes? Do you feel like this is going to open up a whole new conversation and make it more attractive? Or have you guys thought about that from your business model perspective?
Yeah, I definitely agree that this has been a gray area. And I would say that, we deal a lot with employers, but we also have individuals and families. And I think there's
Yeah.
for years been individuals and families that have been using their HSAs to, as you mentioned, both pay for memberships, but also the ancillary services. And for the most part, it's been working, but this has been able to, provide clarity so that employer groups now feel more reassured.
Yeah.
There have been some ways strategically that they can get around some of those rules or make it so that they're,
Correct.
more protected. But now, now they don't necessarily have to have any special, plan designed to get around that. They can just include the direct primary care with the HSA. And then again, whether the employee uses the HSA for the membership versus the ancillary services, both, how they set that up. There's a lot of different options as
Yeah.
that. So yeah, so I would view it as it's going to be a big, I would say it was a hurdle before that we had to jump over, but now I think that there's going to be a lot more employers looking at this.
I 100% agree with that. I mean, and you couple that now with this clarity that we got around telehealth medicine as well. So now you can have telehealth, not jeopardize your HSA. You can have DPC, not jeopardize your HSA. It's becoming more and more attractive to HSA plans in particular. I was always really, really kind of skeptical of them just because I do think it does kibosh good utilization at the same time. Where in your environment, the DPC community really believes that 80% of healthcare roughly could probably be delivered in a primary care setting given adequate time. Would you agree with that statement?
Yeah, I mean, I actually usually quote like 90%, but obviously there are extreme exceptions to this, but for the vast majority of people, I would say 90% of their health needs, the things that we can't provide. I mean, so we still provide again things like, some radiology, we do laboratory services in the office. We do a telemed consultation service. So again, instead of them having to go to an in-person consultation, let's say with a dermatologist, we can send the dermatologist the picture, say, does this need to
Yep.
be biopsied? We can biopsy it there in the office. We send it to the pathologist, from our office. They, give us the diagnosis. So, I mean, all of those things, I feel like, 90% for most people. And then, the exceptions are people that, require surgery or things like that. We still will need to send them into the system for that.
Exactly. It's super important to understand that too. We talk to employers all the time, and when you're an employer-sponsored health plan, right, you're picking the coverage levels for the employees and ultimately the protection for them and their families. But in Greater Madison area, you're also really tying yourself to access to a specific facility as well, right?
Yeah.
That's a big deal. So if you're having this access issue and you're making those determinations, this now opens up a whole new avenue in our opinion, right? You sit in a lot of these meetings, right, where you have employers and consultants and things like that talking about DPC. From your seat, what is one thing that if I'm a company that employs, X number of people, what would you be asking the insurance professionals that they work with on this? What would you tell them to get curious about or have conversations around?
Yeah, I think the biggest thing for me, and I always find it a frustration, and I know employers do, is, year after year, kind of you see the premiums going up. I mean, 10, 15, 20% year after year. And so, rather than just choosing from, a small bucket of insurance plans here locally, I think pushing the broker to think more creatively, more strategically of like, okay, instead of just maintaining the status quo, or maybe we increase the deductible a little bit and that lowers our premium.
Right.
What else can we do to make this, as you mentioned, Mike, not just lower cost, but higher quality? Because as you are competing in the marketplace, and we know, it's hard to find good employees, it's like you can be offering something that someone else is not offering, right? So, I mean, you're
Exactly.
not only
Yeah.
you're differentiating yourself not just on, the benefits, you're giving them a benefit that they might not have access to someplace else. So I think that, I think just pushing brokers to look at DPC as a viable option, and as we've talked about, you can, whether that's fully insured, or self-funded, there's many different ways they can do that.
Exactly. The message that I really want to get out there as we close this is get really, really curious about this stuff, right? Like, it's not going away. A lot of these access issues that we hear, those aren't going away anytime soon either. Now we have this clarity around coupling DPC, direct primary care relationships, with the HSA. There's something to really be had here. So I would really, really stress to people, whoever you work with from a professional level on the insurance consulting side, have some conversations around this. This is something that I think everyone should really wrap their head around. Anything that you would mention, Dr. Hemkes, to give a shout? Why don't you plug Advocate a little bit here, or anything else that you would love to just bring up on this topic as we close things out?
Yeah, I mean, I think for anyone that's interested, of course, I'm happy to talk with you. If you have employers that are kind of very interested, but they're not willing to, pull the trigger on this, we will offer them things like, pilot programs where they can try it
Yeah,
out for 3 months or 6 months, like with their executives or their HR leadership or whoever they decide if they want to take random volunteers. We've done that now with a lot of our larger companies, and they've tried it out for 6 months and then been able to say, okay, yeah, we love the way this works. Because I mean, obviously, people are a little bit resistant to change, and so you can see
right.
the difference in access. Like if you try it out yourself, and then during those open enrollment meetings, those employees can speak about their experience, or you can have some
Exactly.
testimonials. So that also is a great way to kind of incorporate that.
100% agree. Dr. Hemkes, thanks for spending some time with us, and hopefully this will get some people thinking about how we can get creative with this new clarity we have. Much appreciated.
Thanks for doing this. Thanks for doing it, Mike.